We are live.
API ICP postgraduate teaching program. For this evening, we have a case of cardiovascular system. It's going to be discussed by Dr. Ramesh, Senior Assistant Professor from Department of Medicine, Thuthukudi Medical College. Welcome you, sir. And Dr. Balamurugan, the Assistant Professor of Department of Cardiology, and is going to join soon for the discussion. Welcome you, sir. And Dr. Abhinavya, the postgraduate from Thuthukudi Medical College, Department of Medicine, is going to present. Over to Dr. Abhinaya and Dr. Balamurugan and Dr. Ramesh to take over further proceedings. Over to Dr. Abhinaya, please. Start presenting.
A very good evening, all. I thank HOD sir and APA for giving me this opportunity. Today, we are going to present cardiovascular system. Over to Abhinaya. Connection lost, I think.
Dr. Abhinaya or is it Reshma?
Abhinaya, sir. It's Abhinaya.
Sir,
Yeah,
it's Abhinaya, sir. Good evening, sir.
Yeah, connectivity is mentioning as Reshma.
No, sir, it's Abhinaya, sir. But I must log in with Reshma, sir.
Please start presenting, Doctor. Please start presenting. Share your slides, just Doctor. You're not shared your slides. Yeah, make it slideshow. Make it slideshow. Yeah, start presenting. Dr. Balamurugan has joined. Welcome you, sir.
Sir, shall we start, sir?
Please go ahead, Doctor.
Okay, sir. Good morning, sir. Here, a clinical case presentation of cardiovascular system. Here, 62-year-old male patient, resident from Tiruchendur, former by occupation, belonging to upper middle class, upper middle socioeconomic status according to modified Kupuswamy scale, presented with OPD with chief complaints of breathlessness since 3 months and palpitation since 2 months. And in the history of presenting illness, patient was apparently asymptomatic since 3 months before. After that, he developed breathlessness, which was insidious in onset and is gradually progressive. Initially, he developed breathlessness only on walking on 2 flights of stairs, which he was able to climb previously, according to New York Heart Association Class 2. And it's progressive. It's progress over 3 months. Now he had breathlessness even on walking on the level ground for few minutes. It's according to NIGA Class 3. And he also complains of breathlessness after around 5 hours of sleep in the night, after which he wakes up from the sleep and he gasps for breath, and it gets relieved by sitting up for a while for the past 1 month.
Abhinaya, what is your inference?
Sir, here the patient had a breathlessness. It's in a progressive it's a progressive breathlessness. It's in a dyspnea, along with the patient had a paroxysmal nocturnal dyspnea for the past 1 month, sir. So dyspnea, exceptional progressive dyspnea for the past 3 months, and paroxysmal nocturnal dyspnea for the past 1 month, sir. The dyspnea is initially on grade 2. Now it's progress. Now we had end up in grade 3, sir. Grade 3 breathlessness, according to New York Heart Association.
Abhinaya, last question is, what is your understanding of the symptom?
Sir?
What is your understanding of the symptom? What do you understand from the patient's problem list?
It's breathlessness presented with along with the paroxysmal nocturnal dyspnea, sir.
Now, what is the meaning of it? What do you want to infer from this symptom of the patient?
Effect breathlessness due to cardiac.
So it's in a
Or,
cardiovascular system
exhaustion.
breathlessness, sir, because a patient of PND, sir. So it's a more towards cardiovascular system, sir.
The
Okay,
dyspnea
fine.
is due to which part of the cardiac system?
It's a left heart failure, sir, left side.
It's a sign of left heart failure. PND is a sign of left heart failure. What are the other signs of left heart failure? Abhinaya,
Sir?
what are the other signs
Sir,
and symptoms of left heart failure?
sir, patient will have most common symptoms will be paroxysmal nocturnal dyspnea. After the patients will have orthopnea, and the patients will have palpitations and and the patient will have syncope. So if it is aortic predominant, the patient will have syncope, sir.
Okay.
Syncope and
Sometimes
palpitation
resting
are not
tachy-
specific to left heart disease, Dr. Abhinaya. Syncope and palpitation is maybe due to any cardiovascular system. It's not pertaining to left heart disease. Dyspnea, orthopnea, PND. What Dr. Ramesh want to say is dyspnea, orthopnea, PND. First dyspnea comes first, later comes the PND, and then finally orthopnea. Or the hallmark of left heart disease. Okay.
Okay, what is the mechanism of orthopnea?
Sir, yeah, mechanism of orthopnea. Sir, initially, it's if the patient when prone to lying down, there will be an here the patient, the mechanism will be while the patient on sleep, patient enter into NRM sleep, sir. After 3 to 4 hours, a patient went into REM sleep.
That is PND, pa. Orthopnea
Okay,
is
sir.
simple
Sir,
three.
it's due to pulmonary capillary increase in pulmonary capillary wedge pressure, sir. And one
No,
is due to increased pulmonary capillary wedge pressure, and the other one is sudden shifting of venous blood from systemic into pulmonary circulation. That is a more than 400 ml of blood shifted to from pulmonary circulation, and along with ventilation perfusion mismatch and elevation of diaphragm. All this leads to increase in pulmonary capillary wedge pressure, which may lead to orthopnea, sir.
Okay, pa. Yes, 3 symbol.
Yep.
Elimination of gravity, enhanced venous return, and elevation of diaphragm. The 3.
Yes, sir.
This is in additional to PND mechanism. What is the mechanism of PND?
Sir, PND mechanism is initially the patient went to sleep, patient in NRM sleep, sir. After 3 to 5 hours, a patient went to REM sleep, sir. In REM sleep, there will be a sympathetic overactivity will be there. Along with the patient have depressed respiratory center, sir. So what will happen is, which may and there is a catecholamine surge valve also there, which may result in tachycardia, sir. So increase heart rate, which leads to increase in pulmonary congestion, increase in pulmonary congestion. What will happen is respiratory center lags behind, which may leads to pulmonary capillary, which is perceived as an acute dyspnea, sir.
Move on.
Okay, sir. And follow that patient have palpitation since 2 months, which is on regular, occurs on a daily basis, more on exertion, and occurs on reduce on taking rest. It occurs 3 to 5 episodes per day and lasts for 10 minutes. Palpitation not associated with there is no prominent neck veins, and there is no palpitation, post palpitation diuresis or syncope, sir.
So define palpitation. What is palpitation?
Palpitation is defined as an unpleasant awareness of forceful, arrhythmic, and rapid beating of heart, sir.
Unpleasant awareness of one's own heartbeat due to alteration in rate, rhythm, and force of contraction. Okay.
The sudden change in rate, rhythm, force of contraction. Abhinaya.
Yes, sir. Okay, sir.
So what the palpitation will infer you from the history? The palpitation is exertional, what do you infer? Or if it is paroxysmal, what do you infer?
So if it's a paroxysmal palpitation, we have to think for endocrine cause like pheochromocytomas and hypoglycemia, sir.
Arrhythmia. If
If
it is
it's
paroxysmal,
arrhythmias,
simply arrhythmia due to any cause. Okay. Okay. If it is exertional, most probably due to valvular heart disease or volume overloaded states. Okay. Okay, go ahead.
Okay, and the history of EC particularly for the past 2 weeks, sir.
Yes.
And patient had no history of chest pain, and no history of syncope, and no history of orthopnea, and no history of bilateral leg swelling, and no history of abdominal distension, and no history of puffiness of face, and no history of cough with expectoration and hemoptysis, no history of fever with pain and sore throat, and the patient had no history of involuntary movements, no history of skin manifestation like rashes or nodules, no history of recurrent respiratory tract infection, no history of loss of weight, no history of bluish discoloration of tongues, lips, and palms.
Why do you ask hemoptysis in CVS case?
Yes, sir, we will ask, sir.
According to system is according to
Sir,
symptom
if
system is serious, so you ask hemoptysis why?
sir, if the patient with the mitral stenosis, the patient will have left atrial enlargements, which may lead to increased pulmonary capillary wedge pressure, which may lead to hemoptysis. Or if patient had a past history of any drugs, patient or antiplatelets or anticoagulants, we have to look for, sir.
Okay.
Okay, good. Pulmonary apoplexy. Okay. Okay.
Sir, shall I move, sir?
Yes.
Yes, Abhinaya, go ahead.
Past history. Patient diagnosed to a systemic hypertension 5 years back, and he started on treatment. Patient took treatment on irregular basis. Lost intake of medication 1 month before. Patient stopped antihypertensive by himself. He is not a known case of diabetes mellitus, coronary artery disease, a bronchial asthma, pulmonary tuberculosis, and no history of thyroid disorders and convulsions. No history of fever with migratory joint pain, and migratory joint pain in childhood are taking once every 21 days injection, and no history of any surgery and no history of any sexually transmitted disease, sir.
So you ask history of migratory
Yes, sir.
polyarthritis.
Migratory. Yes, sir.
Having in mind of rheumatic fever. Okay.
Yes, sir.
What
Yes, sir.
other what are the other causes disease will have migratory polyarthritis?
Uh, uh, rheumatoid arthritis and dengue will.
No. Have you heard of gram-negative meningococcal gonococcal arthritis? Gram-negative
Reactive
arthritis.
arthritis will have
Reactive
arthritis. Beta syndromes will have
acute leukemias. Acute leukemias, sometimes SLE, may also mimic. Okay. Will have migratory polyarthritis. Okay, go ahead.
Personal history. A patient took mixed diet. He's a reformed smoker, taking BD 1 packets per day for 20 years, and he stopped 5 years ago. The packets will be 20, and the patient is not a tobacco chewer and not an alcoholic. Its appetite is normal. No, sleep is disturbed. Bowel and bladder habits were normal, sir.
Okay.
What is the importance of alcoholic in alcohol history in cardiovascular system?
To rule out alcoholic cardiomyopathy, sir.
Okay,
If patients will have a patient on alcohol, they're more prone to get cardiomyopathy. So to rule out alcoholic-induced cardiomyopathy, we have to take history of sir.
What is holiday heart syndrome? What is holiday heart syndrome?
Sir, holiday heart syndrome. Patient sudden binge of alcohol on weekends, sir, which may leads to which may leads to atrial fibrillation, which may lead to arrhythmias and which may lead to death, sir.
Okay. Another is, sir, mild to moderate alcohol intake will produce a vasodilation and fall in BP. Binge of alcohol will
Okay,
produce
sir.
increase in BP. Okay. And
Okay,
also
sir.
some arrhythmias are also produced due to alcohol.
Okay.
Okay. Move on.
Family history, no history of similar complaints, no history of similar complaints in the family members, and no history of engaged death in family. Treatment history. For the above mentioned complaints, patient went into nearby local hospitals 3 days before, and he got evaluated and he got referred here for cardiology opinion, sir.
So with this inference, what do you understand? With this story, what do you
Sir,
understand?
for in family history, the history of engaged death is to rule out HOCM, sir.
I'm not asking family history. From all the
Treatment
history,
history,
your
sir.
present history, from your complaint, present history,
Uh,
personal family
Sir,
history.
here,
What do you
sir,
infer?
from history, here a old age male patient with systemic hypertension for 5 years on irregular treatment with the smokers, with complaints of exertional dyspnea, with exertional palpitation, with EC irregularity, with no other symptoms pertaining to RS or abdominal or central nervous system. That's more towards the system is more toward cardiovascular system, sir.
Okay. Of which, what do you highlight? Cardiovascular system
Sir,
involving
this cardiovascular system, which have valvular pathology, sir, which is a valvular pathology, which includes
cardiovascular
left-sided
system,
valvular
so
pathology,
left heart disease,
sir.
left-sided valvular pathology.
Left-sided disease,
Wait,
left-sided valvular pathology.
wait. What made you to think to go straight away into left-sided valvular pathology? Can it
Sir,
be
if for
simple
the patient,
ischemic heart disease?
yes, sir.
He's an elderly smoker with exertional dyspnea. Can it be ischemic heart disease?
Yes,
Coronary
sir.
artery disease?
Possible, sir. Possible we do that, sir.
Is it possible or not?
It is possible, sir. Patient are also have old age with
With the
known history of
history,
smoker.
available history, only he didn't go for examination. Okay. You didn't go
Sir.
for examination. So with the available personal history, you have to tell all the possibilities here. All the
Sir, okay, sir. The possibility of maybe patient will have ischemic heart disease will be there, sir. Or patient
you
due
can
to
defend
cardiomyopathy. Sir?
does the patient has got angina, Dr. Abhinaya?
No, sir. Patient does not have any angina, sir.
So you can defend like this.
Does
So
not
patient
give
does not
complaints
have of angina,
does not
maybe
give
probably
complaints.
exertional dyspnea is maybe an anginal equivalent.
Yes, sir.
Maybe possibility of coronary artery disease and possibility of left heart disease. Left heart disease involving which valve?
Either mitral valve. Mitral valve will also present breathlessness and palpitation, and aortic valve also present with palpitation, sir. Palpitation with the breathlessness, sir. Most likely mitral, sir.
Why there is angina in mitral valvular heart disease?
Sir?
What is the mechanism? Mechanism of angina, anginal pain in mitral valvular heart disease. Either MS or MR. What is the mechanism?
Sir, sir, if it is sir, angina is seen in AS and along with the AR, sir. If it's angina due to aortic stenosis, it's made due to reduced stroke volume, decreased stroke volume, which leads to reduced coronary perfusions and sometimes it's compression of coronaries by hypertrophied myocardium. All this which leads to decreased oxygen supply and increased demand, sir.
It's called as throttling
In
effect.
simple words, aortic stenosis have hypertrophied myocardium, which leads to decreased supply and increased demand, sir.
What are the symptom triad of aortic stenosis?
Sir,
Symptom. What is the
Sir,
triad
aortic
of
stenosis,
symptoms?
angina, dyspnea, symptom.
Okay, which will come? Can you assess the prognosis with this?
Sir, 3,
Okay,
5 years, 3 years, 1 year, sir.
for what? An aortic stenosis
Sir, if it's
patient, severe aortic stenosis, if he has got angina, his survival
sir,
rate is
mortality will, sir,
5
mortality
years.
will
5
be
years.
high.
Dyspnea 3 years. And if he has got syncope, it is 2 years. Okay.
1 year, sir.
Yes. Okay.
Okay, sir.
Mm.
General examination, sir. General examination, on examination, patient comfortable at rest. Patient is conscious, oriented to time, place, and person. Is afebrile. Hydration fat. Height is 158 centimeter. Weight is for 60 kilogram. BMI will be 24 kilogram per meter square. Patient had no pallor and no ictus, no cyanosis, no clubbing, no pedal edema, no significant lymphadenopathy, sir.
So if suppose if filter is there, what is your opinion? So jaundice in
So if
CVS system.
congestive hepatomegaly will have caused jaundice, sir. Or if
Okay,
patient with the infected endocarditis also have jaundice, sir.
then
And uh, uh,
what about prosthetic valve? Prosthetic valve.
hemolysis in prosthetic valve, there will be hemolysis which may lead to jaundice, sir.
What about pallor? Pallor in cardiovascular system.
Sir, pallor in cardiovascular system, so the infected endocarditis will have pallor, sir. Or patient with the AV shunt or AV malformation will have pallor, sir. In the same thing, the patient will have on antiplatelets or anticoagulants, a patient on a warfarin, which may leads to bleeding, which may leads to pallor, sir. Here the prosthetic valve also plays a role. So here the patient on prosthetic valve, which may leads to sequestered hemolysis, which may leads to pallor, sir.
Okay.
Generally, heart failure, if there is anemia, you may agree with the heart failure symptoms. So you have to correct anemia. Most of the time, we will miss the anemia. We will concentrate on heart failure alone by diuretics, all those things. So you have to see the evaluate the anemia by looking for serum ferritin and all. And you have to correct the anemia also. That will give good results in treatment of heart failure. Okay, go ahead.
Yes, sir. There is no markers for on a general examination. There will be no markers for a congenital heart disease and no markers for infected endocarditis, and there is no markers for a rheumatic heart disease and no marker for tuberculosis or HIV and no markers for coronary artery disease seen in this patient, sir.
So what are the markers of congenital heart disease?
So congenital heart disease patient will have cyanosis, clubbing, polycythemia, IH palate, hypertelorism, low set ears, along with syndactyly, polydactyly, arachnodactyly will be there, sir. Or the patient will have pectus excavatum or pectus carinatums will have to see, and the absent radius will be there, and upper segment and lower segment inequality will be seen, sir.
When will you say it's a low set year? What is the criteria for low set year?
Sir, we have to draw an imaginary line, sir. Imaginary line from outer and outer canthus of eyes to the to tragus tragus, sir. If it is less than 1/3 of this height, which may be called as a low set here, sir.
Why do you are looking for markers of congenital heart disease in a 60-year-old man who is presenting with only 3 months symptoms? Dr. Abhinaya?
So sometimes atrial septal defects will have a late presentation. So
Otherwise, what are the adult congenital heart disease of adults? What are the congenital heart disease seen in adults? One is ASD, then
Marfans, which may leads to mitral valve prolapse, or
that is myxomatous valve disease, not comes under P. That comes here. Okay.
Pulmonary valve stenosis.
Okay. Okay, good then. Adult retralogy fellow. Okay.
Adult of will be.
ASD.
Adult of will be.
Okay. Why the ASD presents with the later age group in 30s and 40s?
So, initially there will be an left to right shunt will be there, sir. When the
Yes.
when the left to right shunts will be the patient when for Eisenmenger they came up, sir.
No.
What about the pressure? Biatrial pressure, biventricular, interatrial pressure. You have an idea about the atrial pressure, right atrial and left atrial pressure.
So when
what Dr.
right
Ramesh expect you is ASD is present from the birth itself. Okay. When but the patient becomes symptomatic at the third or fourth decade. That is that takes place as there develops the shunt. So before that, the ASD will be there. There won't be any significant shunt left right shunt. As the patient develops significant left right shunt, the patient develops the symptoms. So Ramesh, Dr. Ramesh, what expects you is when the shunt develops, why the shunt develops later. That is what he was asking. Are you able to understand, Abhinaya?
Yes, sir.
Yes?
No,
Yes? Are you there?
sir.
Okay, move on.
Okay, you refer this as the patient third or fourth decade when the patient develops hypertension or coronary artery disease. The complaints of the LV, when the LV loses complaints, there results pressure difference. Okay. And the patient develops left right shunt. You read about that, then we'll discuss it later. Okay, go ahead.
Okay, sir. White
The
test, pulse is what?
markers of coronary heart disease. What are the markers of coronary heart disease? You have written like that.
Sir, xanthoma will be there, sir. Xanthelasma will be there. And the patient will have arcus analysis and the earlobe crease, diagonal earlobe crease will be there, sir. Obesity is the most common marker of coronary artery disease.
What is Frank sign? Frank sign. What is Frank sign?
Earlobe.
Yes, earlobe crease. And that's a locomotor brake. Locomotor brake is a sign of atherosclerosis.
Okay, sir.
Okay, move on to next slide.
Okay, sir. Here pulse is 103 beats per minute, which is in a regular in rhythm, normal volume. The character of vessels is normal, and there is no radio-radial and there is no radio-femoral delay, sir. And blood pressure measured in all four limbs. In left arm, measured in sitting portion, which shows 150 by 90. In a right arm, in sitting 130 by 80. In left leg in prone position, 160 by 70. In right leg prone, 140 by 80, sir.
What are the conditions produce a radio-radial delay and radio-femoral delay?
Sir, radiofemoral delay is most commonly seen in coarctation of aorta, sir.
Okay. Is
Uh,
pre-ductal or
uh,
post-ductal? Pre-ductal or
uh,
post-ductal?
Post-ductal, sir.
Okay. What about pre-ductal
Post-ductal.
coarctation of aorta?
Pre-ductal radial delay will be there, sir.
Okay.
And causes
Is
for
it possible to measure radiofemoral delay, Dr. Abhinaya? Is it
Sir?
possible to record the radiofemoral delay clinically? Honestly, tell me honestly.
Sir,
Huh?
no, sir. No, sir.
Oh, then how will it find out the coarctation by simply clinical examination? Whether if you palpate both the pulses, whether the pulses are felt equally on both sides, or whether all the peripheral pulses are felt equally on both upper limb and lower limb. Okay, that will give a clue. And also see the BP, left arm, right arm, that will give a clue. That is a simple
Yes, sir.
test you can find out whether there is coarctation. Okay. Yes.
For a radial delay, Takeda arthritis is the most common, or a patient with cervical rupture, thoracic inlet syndrome will may cause radial delay, or pre-subclavian coarctation of aorta, or aortic arch aneurysm will also cover radial delay, sir.
What about supravalvular aortic stenosis? There are 3 types of aortic stenosis there, isn't it? What about supravalvular aortic stenosis? What about the pulse in supravalvular aortic stenosis? In the right limb, right upper limb and left upper limb?
It will be diminished, sir. It will be a decrease on left side.
What is Coanda effect? Go and read. Next slide.
Oh, okay, sir. Respirator rate will be 18 cycles per minute. It is in a regular, it's an abdominal thoracic type. So, SpO2 97 will, saturation will be 97% in room. Temperature will be 97.8 degree Fahrenheit, and JVP is not elevated.
Okay, wait. Respiratory pattern is abdominal thoracic. So is it male patient, isn't it?
Yes, it's a male patient.
What about a pattern in female patient?
It's a thoraco-abdominal pattern, sir.
Why in male patient abdominal thoracic? Why in female is a thoraco-abdominal?
Sir, in male patient, the internal intercostal muscles are well formed in females, sir. So there will be thoraco-abdominal pattern will be more visible. In
so the females are
males,
using intercostal muscles. Females are using intercostal muscles. So the males are using
abdominal muscles, sir.
Diaphragm. Nah? So is there any conditions male also became thoraco-abdominal? Is there any condition?
Massive ascites, sir. When patient will have and the patient will have peritonitis also.
They can't use diaphragm, so the breathing pattern became thoraco-abdominal.
Thoraco-abdominal, sir.
Okay, good.
Sir, on a systemic examination, chest wall is
So JVP, did
bilaterally
you concentrate on JVP? Is there any findings? No, there no findings in JVP.
So JVP will not.
Did you did all the maneuvers by putting the patient 45 degrees and all those things?
Yes, sir, we done, sir.
You didn't get a good JVP.
No, sir, we didn't get JVP, sir.
So you said patient is having exertional dyspnea, all those things. That's why we are asking.
No, sir, no. Examination JVP will not. We don't get any JVP. We don't get JVP, sir.
Okay. So why the internal jugular vein you are looking, not external jugular vein in JVP?
Sir, because internal jugular vein has state communications with the right atrium, sir, and it has a less valve, and it is less influenced by facial glands, and there will be if sympathetic less affected by sympathetic system, sir. Compared to extrajugular vein has more valve. It is more kinked by facial glands, and there is not in state communications with the right atrium, sir. Or if patient went for shock, there will be vasoconstriction will be there. It's more common in extrajugular vein.
Okay.
which makes
We
extrajugular
are
veins more flexible.
we are taking the right side of internal jugular vein rather than left side.
Because it's direct communications with the right atrium, sir.
Left
And it has
innominate
less
vein
flaps.
can get compressed between the sternum and the aortic arch generally. Okay. That is also the reason. Right IJV is a straight line with RA, and left innominate vein can get compressed between the sternum and the aortic arch in the elderly. So we are taking right side. What is Kussmaul sign?
Sir, usually on inspiration, there will be in Kussmaul sign exaggerated fall of JVP, sir.
Then what is Frederick sign?
Sir, Frederick sign is seen in rapid fall and rapid rise in JVP, sir. It's
Condition?
seen in constrictive pericarditis.
What does the JVP gives? What does it indicate?
Sir.
So what does JVP? What information the JVP gives you in general?
So it gives you right heart failure, sir.
Right heart
Right
failure
sided
or
pathology.
right?
JVP gives
Right.
information
Right
more about
atrial.
right side pathology, sir.
So the JVP is the oscillating top of the column of blood in the proximal portion of IJV, representing the volumetric changes that faithfully reflects the RA pressure at all the stages of cardiac failure. Okay. It's the oscillating top of the column of blood in the proximal portion of IJV represents the volumetric changes that faithfully represents the right atrial pressure at all the stages of cardiac cycle. This is a definition you have to say. Okay, this so in this case it has got JVP has got no role. So the JVP is not elevated. Okay.
Yeah.
Can you get elevated JVP in aortic stenosis?
Yes, sir. We get elevated JVP in aortic stenosis, sir. There will be a large giant A wave seen in aortic stenosis, sir.
How? It's a left heart pathology. Right side. Right side. Does right side of failure takes place in aortic stenosis? Then how it happens?
So, which may leads to left ventricular hypertrophy, which may leads to left atrium
Interventricular
forward, backwards.
septal hypertrophy. Ventricular septal hypertrophy. So, right? Aortic stenosis leads to LVH. The interventricular septum gets hypertrophy, that gets bulges into right ventricle. Okay, right ventricle, and the right ventricle pressures are reflected the RA and then into JVP as reflected as A waves.
Okay.
Okay. Is there any name for this? This effect. Is there any name for this effect?
Brenham
Burnham effect. Have you heard of that? Okay. Okay, go ahead. Yes.
Okay, so on system examination. So shall I move, sir?
Move, go ahead.
Yes.
Okay, sir. On a system examination, chest wall is bilaterally symmetrical and elliptical in shape, and apex plate is felt in left sixth intercostal space, lateral to mid-clavicular line. There will be no precordial bulge or no visible pulsation, no scars or no sinuses or no directed veins will be seen, and there is no spinal deformity. Trachea appears to be in midline, sir.
Abhinaya, what is the importance of precordial bulge? What is the significance of precordial bulge? If it is there, syndicate?
Sir, right ventricular dilatation, sir.
Simply,
or it indicates congenital heart disease, sir, because
that is okay. It's a chronic right ventricular hypertrophy. The origin is before the period of ossification. So if RV is started before the ossifications, you will get tricketed bulge. Otherwise, it won't be there. Okay, what are the other signs of right ventricular hypertrophy? Inspection.
uh,
What are the other findings in inspection of RVH?
parasternal pulsations, sir.
Parasternal heave.
Parasternal,
Then-
heave, and
then
epigastric pulsations, sir.
good. Epigastric pulsation. Okay, sure.
So what does the apical impulse infer in this case?
Sir, here it infers heart will be dilated and shifted, which increase cardiomegaly will be. There's a shifting of left ventricular to outside, sir. There's no outward and downward shift.
Only outwards or downwards? Only outwards
both
or
outward
down
and
and out?
It's both
Down and
outward and downward shift, down and outward shifting of left ventricles will be there, sir.
Probably it's this volume overload, isn't it?
Yes, sir. It's a volume overload.
So it gives information about what is happening in the left ventricle. Whether the left ventricle is has got an eccentric hypertrophy or concentric hypertrophy. If the left ventricle has got eccentric hypertrophy, is that where the LV is dilated as well as enlarged. In concentric hypertrophy, only the muscle mass is thickened. In concentric hypertrophy, you will get in pressure loaded states. Whereas eccentric hypertrophy, you will get in volume overload states. So these clues will get from the apical impulse, position and character of the apical impulse. So in volume overload states, we'll get down and out apical impulse. Whereas in pressure load states, we'll get only lateral shift of the apical impulse. Okay. Yes, Abhinay, go ahead.
Okay. On palpation, all inspectory findings were confirmed, and apex fetus felt at left 6th intercostal space 1.5 centimeter lateral to mid-clavicular line. It is hyperdynamic in nature. On palpation of mitral area, there will be a systolic thrill will be there, sir, and there is no parasternal heave, and there is no palpable sounds, and trachea appears in midline.
How will you check the thrill? How will you examine the thrill?
Sir, thrill will be examined with the metacarpal itself.
What is tapping apical impulse? What is tapping?
Sir, it's a palpable S1 is called as a tapping apical impulse, sir. It's seen in mitral stenosis.
Good.
Is it normal or abnormal? Is anything happens in left ventricle in mitral stenosis? Will any change happen in happen to left ventricle in mitral stenosis? Left ventricle will be normal or will be abnormal in mitral stenosis?
Sir, left ventricle will be normal, sir. Left ventricle will be normal in mitral stenosis.
Then why you are getting left heart signs like dyspnea, orthopnea, PND?
Because of pulmonary increase in mitral stenosis may lead to left atrial, which increase left atrial pressure, which may lead to pulmonary capillary pressure, which may lead to pulmonary capillary due to increase in pulmonary capillary pressure.
The left heart the symptoms in mitral stenosis are due to left heart failure, otherwise left sided failure, left atrial failure that leads to pulmonary venous hypertension and pulmonary congestion and all. Left ventricle will be normal. Are you able to understand? Left ventricle will be normal. All those things happens because of the left atrial abnormality, left atrial dilatation, and left heart failure. The left heart failure in mitral stenosis is due to left atrial dilatation and atrial dysfunction that leads to pulmonary venous congestion and pulmonary hypertension. Okay. Yes.
What is the
What is
significance of this thrill? Okay, sir. You can proceed, sir.
How will you
Vinaya?
differentiate a heaving apical impulse and hyperdynamic apical impulse? Heaving
So
and
the
hyperdynamic.
heaving apical impulse seen in pressure overload status, sir.
Okay.
Hyperdynamic apical impulse seen in volume overload state, sir. Pressure heaving seen in aortic stenosis or a patient with coarctation of aorta or
Clinically, how will you
hypertrophy.
differentiate whether it is clinically? How will you say whether it's a heaving apical impulse or hyperdynamic apical impulse?
Its heaving apical impulse is confined to one intercostal space, sir. And
Okay.
the duration will be occupies more than 2/3 of systole, and there more than 2/3 of systole in heaving, sir. But in hyperdynamic,
Sustained.
it
Just
occupies more
sustained.
than one intercostal. Yes, sir.
It's a sustained impulse, whereas
Hyperdynamic
hyperdynamic is a ill-sustained. Okay.
is sustained.
And it's diffuse. Yes, this apical impulse will give you information about the left ventricle. Then, what clinical sign will give information about right ventricle?
Right.
For right ventricle, what are the signs you look for? So, from the apical impulse, you get all the clues like whether the LV is normal or enlarged or eccentric hypertrophy or concentric hypertrophy due to pressure overload or volume overload, like that. Oh, like that. For RV, what are the clues, clinical clues? We'll get whether the RV enlargement or RV volume overload or RV hypertrophy.
Epigastric pulsation, sir.
Okay. Not only epigastric, parasternal pulsation. Parasternal pulsation that will get mostly in case of or severe volume overload state in ASD, right atrium, right ventricle dilatation in ASD, volume overload ASD will produce a parasternal pulsation that will call it a tumultuous pericardium. Tumultuous pericardium. You'll get the parasternal pulsations. Also epigastric pulsations, as you said. And if the RV is pressure overload hypertrophy, you will get a parasternal heave. RV lift. Okay. Can there be parasternal heave other than RV hypertrophy? Is there any other cause that will produce RV hypertrophy? Parasternal heave other than RV hypertrophy?
Left.
You able to understand my question? Usually parasternal heave is seen in right ventricular hypertrophy. Is there any other condition that will produce any other pathology that will produce parasternal heave?
Left atrial pathology, sir.
Very good, very good. Left atrial dilatation. And there is a giant left atrial dilatation. In case of severe MR, you will get a giant left atrium. There also you will get a parasternal heave. Okay.
Yes.
Go ahead.
On percussion, right heart borders corresponds to right sternal margin. Sorry, so it's a right sternal margin. And left heart border, that's a dullness outside apex will be seen. And the aortic area will be resonant and pulmonary area will be resonance.
So did you really percuss this old man?
Sir?
Did you really percuss this old man with having dyspnea and all? Did you percuss him? Are you supposed to do percussion in
we done some but patient not cooperate, but still we done.
I don't know. Other Ramesh has to tell whether you are supposed to do percussion in all CVS cases or not.
No, sir. We don't have to focus in all serious cases, sir.
Sir, Ramesh, examiners are expecting percussion from medical side?
It depends upon the examiner, sir.
Okay. So I think the percussion you will get one important clinical condition. The percussion will give clues is pericardial effusion. There you can get percussion. You have to see the apical impulse. Most of the time it will not be seen. So if the percussion or dullness of the cardiac border is confined to the apical impulse, that is, the apical impulse is usually the down and outermost part of the definite cardiac impulse. It will be the outermost part of the heart. So beyond that, there won't be any cardiac dullness in normal heart. Whereas in case of pericardial effusion, you will get a apical impulse. Beyond that, the percussion dullness note extends beyond that apical impulse in case of pericardial effusion. Whereas in case of cardiomegaly, you will get only the apical impulse will be down and out. Beyond that, there won't be any dull cardiac note. So this is a old clinical sign. They say that enlarged heart is maybe due to a dilated heart or it's the pericardial effusion. So if the apical impulse is down and outermost of the heart border by doing percussion, then it is an enlarged heart. And if the heart border extends beyond the apical impulse, heart dullness extends, then it may be some fluid beyond that heart border, maybe pericardial effusion. Right?
Yes, sir.
Okay, the examiner asks some questions on percussion. You have to say all those things: pericardial effusion, dullness. Then in case of pulmonary artery dilatation or pulmonary hypertension, it will have a dull note on second space. You can tell all those things. Okay. Yes.
Sir, on auscultation of mitral area, S1 is ear and it's soft, and high pitched, soft blowing pan-systolic murmur of grade 4 intensity, which is best heard at the diaphragm on the stethoscope in left lateral position of patient ill at left lateral position at the best heard in height of expiration, sir.
Okay,
And the
Abhinaya,
murmur is radiated to the sir.
Yes, if you mention a murmur, you should tell like that. 4/4 or 4/6, like that. What is the
4/6,
grading of
sir.
systolic murmur? 4/6. What about the grading of diastolic murmur?
Diastolic murmur will have 4 grades, sir.
Here is systole, isn't it? Okay, you should
Sir,
tell like that.
systolic
4/6.
will have 6 grades. Okay, sir.
Okay.
What about S2? Only S1 is heard.
Sir, S1 is here, sir, but as a pan-systolic murmur, we are not able to hear the S2, sir.
So pan-systolic murmur engulfing the stroke, isn't it? So it indicates
sir.
it is severity. So severe MR. So there is thrill also there. So severe MR, the second also engulfed by pan-systolic murmur. Where is the murmur radiation? Axilla.
So left axilla and also to the inferior angle of scapula, sir.
Which leaflet is involved? Which leaflet is involved?
So it indicates anterior leaflet will be involved, sir.
Okay. Suppose if posterior leaflet involved, where is the radiation?
It's radiate to anterior precordium, sir. It radiates up to it radiates to base of heart, sir. Anterior precordium and up to the pulmonary area. Base of heart, we hear the murmur. If it's posterior mitral valve, involved, sir. If it's anterior, it radiates to the left axilla and also to the inferior angle of scapula, sir.
Okay.
What is Gallavadian phenomenon? What is Gallavadian phenomenon? Gallavadian phenomenon. You are not aware?
Gallavadian seen in aortic stenosis.
Okay. What happened to the murmur, aortic stenotic murmur?
There will be MDM murmur which he had in apex.
MDM.
In
not
MDM.
aortic stenosis.
So the musical murmur of mid-systolic murmur of aortic stenosis, mid-systolic murmur or erection systolic murmur of aortic stenosis is heard with a higher intensity at the aortic area. If you go on auscultating the murmur towards by inch-by-inch auscultation, if you do along the mitral area, like the cross belt area, if you start from the aortic area to mitral area by inch-by-inch auscultation, the murmur gradually decreases and then it again increases and had a musical quality in the mitral area. This shape of the intensity of the murmur will be like a hourglass. So it will be very harsh murmur will be had in the aortic area. Then it gradually reduces like a hourglass in the mid, and then again it captures the musical quality in the mitral area. This hourglass conduction of the mid-systolic murmur of aortic stenosis, which is had as musical quality in mitral area, is called Galaverian phenomenon. Mostly it happens in calcific aortic stenosis due to the vibration of the aortic leaflet, calcified aortic leaflets. Okay. You said the S1 is soft. So what are the predeterminants for the intensity of the first heart sound? What are the factors that determine the first heart sound, soft or loud? Yes, are you able
From
to?
if it's been sorry, like if a loud experiments, what they will infer like that.
What are the basic prerequisites which determine the intensity of S1? Factors that affect the intensity of S1. If the S1 is, for example, one is pliability of the wall. Okay. Pliability of the wall, mobility, that is mobility of the wall, and the position of the leaflets at the onset of systole, whether it is receded into the LA or down into the LV, and the status of the ventricular contraction, and the transmission characters of the thoracic wall. So this one is soft, this one is loud. What are the factors that determine? Now you should know all whether the how is the wall leaflets, whether it is pliable or calcified. Then mobility of the wall, then status of the ventricular contraction. So all those things that determine the valve intensity of the sound. That is AV valve, because S1 is due to AV valve closure. Yes. So here the S1 is soft according to you, and there is a pansystolic murmur in the mitral area. Okay, go ahead. Ramesh, do you want to interfere anything here?
Yes, sir. Go ahead, sir.
So then, in the oscillation of tricuspid area, S1, S2 will be here. The same high pitch soft low pansystolic murmur murmur will radiate to the pulmonary area with the decreased intensity here.
One thing, Abhinaya, you tell that SNS to heard, murmur is heard like that. Murmur, don't say that murmur will be heard, SNS to will be heard. It is heard. You have to examine the patient. Okay.
Okay. And pulmonary area, S1, S2 here. The same murmur radiated to the pulmonary area with a decreased intensity. In neoaortic area, S1, S2 here, and the same murmur
Did
which
you
here in mitral
concentrate
area.
anything on pulmonary area? What did you concentrate on the pulmonary area?
So now, S2, sir, we have to look for A2 and P2, sir.
Okay, okay. In this case, what about a P2
Sir,
in this case?
Here, P2 will be normal.
It is normal. Why?
Patient that does not develop, it's acute case that they do not develop pulmonary hypertension.
Did you
There is no
expect
pulmonary
anything? What do you expect in this case? What do you anticipate? P2, you wanted P2 to be normal in this case or P2 to be loud in this case?
So in P2 will be, if it's chronic, there will be a loud P2 will be there, sir. It's an acute, patient does not develop pulmonary hypertension, so it will be normal.
So why you are saying it is acute? How you are saying? You said history of 3 months, insidious onset, all those things. And how can it be acute? Yes. You said PND, dyspnea PND in this case. Okay. That indirectly means that pulmonary capillary wedge pressure is more than 80.
Increased, sir.
increased. Then what
Yes,
you then before auscultating pulmonary area, what do you expect? From the history wise, you have got all those things for pulmonary venous congestion, raised pulmonary wedge pressure from the history wise, and there is dyspnea, acute onset. Then what do you, from the auscultation, what do you expect? Yes? You want a loud P2 or a normal P2?
Loud P2, sir.
Loud P2, good. Okay. And one thing you mind that the P2 of pulmonary hypertension, it need not be due to chronic etiology. You can get a loud P2 pulmonary hypertension all of a sudden in acute cases also. Okay. Okay, go ahead.
Okay, sir. And aortic area is when S2A, there will be no murmur, sir. And auscultation of other areas, like auscultation of epigastrium, clavicular area, carotid area, it will be normal, sir.
Wait, Abhinaya, S2 is normal?
S2 is normal, sir.
Normal. Okay.
Shall I move, sir?
Yes, go ahead.
Sir, other system examination, respiratory system, upper respiratory tract examination, normal, there will be no abnormalities. Lower respiratory tract examination, inspection, respiratory movements equal on both sides, and no visible pulsation, sinuses or scars will be there. And the palpation, respiratory movements bilaterally equal on both sides. Percussion, resonant node or over lung fields. Auscultation is a normal vesicular blood zone, seared all over lung fields. In abdominal examination, it is soft. Bolsons will be here. Liver span will be 10 centimeter. Normal, no organomegaly, and there is no venosum, and there is no bruit here, sir.
Okay, what are the conditions to produce bruit?
Sir, sir, what are the if 50% of artery will be occluded or 50 to 70% of artery will be occluded, which will result in bruit, sir. We are look for any renal artery bruits or we here look for any renal artery bruit we have to look for, sir.
Okay, diagnosis.
So still central nervous system examination,
Okay.
higher mental functions will be normal. So cranial nerve examinations will be normal. Sensory motor and cerebral examinations will be normal. So other
Is
system,
there any
thyroid.
conditions? Wait.
Sir?
Is there any cardiovascular conditions affect the central nervous system?
Yes, sir. There will be if AF, the patient will be more prone to get cardioembolic stroke, sir. If it's a patient with AS, they are prone to get syncope, sir.
Okay, then.
We look for any hemiplegias or hemiplegia we have to look for, sir. And
What are the conditions? What about infertility endocarditis?
yes, sir.
What about the congenital heart disease, TOF? What is the central nervous system manifestation in TOF? Tetralogy fellow.
seizure, sir,
No.
or abscess, cerebral abscess.
It's cerebral abscess, no? Cerebral abscess. For up to 2 years is infarct. After 2 years is they're prone for cerebral abscess. Okay. Okay, move on.
So provisional diagnosis, it's a case of acquired heart disease with valvular involvement. The possible etiology, valvular involvement, this is severe mitral regurgitation. The possible etiology between rheumatic or degenerative ischemic. The patient will have no pulmonary hypertension. There is no atrial fibrillation, no signs of infected endocarditis, and no signs of congestive cardiac failure. The patient in normal sinus rhythm, sir.
Total diagnosis is
It's a case of acquired heart disease with severe MR, sir.
MR. Okay. How old is it? MR.
Use-
Mitral is not the. Okay, sir, proceed.
Sir?
Yeah, you say one etiology. You have said all the etiologies: rheumatic, degenerative, ischemic. Okay, to answer to Dr. Ramesh, severe. He asked
What are the
why it is severe MR. Wait,
what's the
severe
point
MR.
of having MR?
The patient will have a systolic thrill, sir, and the
Okay.
presence of apical impulse will be shifted outward and downward, sir. And the patient will have grade 4 pansystolic murmur, which radiate to axilla and intrascapular areas. And
Okay. How will you assess the
What
severity
are-
in okay, sir.
That's
Only
severity of
assess-
MR. He's asking
severity
clinical
of
signs for severe MR. What are the clinical signs of severe MR?
presence of left ventricular hypertrophy, sir, and presence of systolic thrill with a loud murmur over the apical area, and presence of apical mid-diastolic flow murmur, sir, or
Good.
presence of
Apical
S3.
mid-diastolic flow murmur. That is very important. Okay, that would
Apical
increase the
mid-diastolic
flow across the mitral valve. Yes, that is a point for severe MR.
Then what about the second heart sound?
Yes. So
Is there any splitting in severe MR?
severe MR, S2 will, yes, sir, there will be a split in severe MR, sir.
Why? Due to yearly IOT closure, na? So yearly IOT closure. Okay. What about the S3?
So if the patient went for a severe MI, severe mitral regurgitation, S3 will be heard, sir, heard in apical areas. Apical areas, S3 will be heard, sir.
Okay. What about in this patient?
He's asking whether
patient-
S3 will acute MR, which will be heard. Whether S3 will be heard in acute MR or S4 will be heard in acute MR. In acute MR, in chronic MR, what additional sound you will have? S3 or S4?
So acute
In
MR,
acute MR, what will you have?
S3 will be heard, sir.
No. In acute MR, you will have a S4 because the S4 is produced due to forced atrial contraction against a non-compliant LV. Whereas S3 is due to increased filling of the ventricle that happens in chronic MR. Chronic severe MR, you will get the S3. In acute severe MR, you will get the pathology is mainly in the left atrium. So you will get the atrium contracts against the non-compliant LV. So that is produced S4 in acute MR. Whereas in all the other conditions, chronic MR, acute AR, chronic AR, all those things you will have S3. Whereas S4 is classical for acute MR. It's a pathognomic of acute MR. Yes, Ramesh.
Okay, sir. Vinaya, usually in the exam, for PG exam, they kept multivalvular heart disease, or with suppose the patient sometimes have both mitral stenosis and mitral regurgitation. So, in such a situation, how will you assess the severity? Whether MS is severe or MR is severe, how will you assess the severity in both conditions?
Okay, sir. If it is
But this patient have
associated
both
with,
MS and MR. Okay, how will you assess the
yes, sir.
severity?
Sir, if the patient will have a MS means the patient, there will be opening snap will be there, sir, and
Okay,
there will
sorry.
be loud S1 will be there, and
Okay.
if it's MS, in symptom wise, the patient will have hemoptysis, and
Okay.
patient a patient have hemoptysis, chest pain. When we look for vitals, if it is MS predominant means the patient will have a low volume pulse, and usually systolic BP will be low, and the patient will have left parasternal area.
Okay, wait.
Left parasternal area.
How will you assess the volume?
Volume systolic BP minus diastolic BP, sir. In pulse,
That is
volume will be
pressure.
assessed by systolic BP minus diastolic BP, sir.
Oh, this is a rough assessment. Na? So this is pulse pressure. If pulse pressure narrow, your volume will be
Uh, pulse low volume, sir.
okay. Okay, good. If pulse pressure is high, your volume will be high volume. Okay.
High volume, sir. Sorry, on auscultation,
Otherwise, what
there
are
will
the
be an
clinical points for severe MS? Severe MS.
there will auscultation findings of it.
Any finding, any
Any
finding.
finding.
Sir, okay, sir. If it's a severe
Severe MS.
severe MS, there will be a low volume pulse will be there, sir. And
Okay.
usually systolic BP will be low, and the patient will have a left parasternal heave, and the opening snap will be there, sir.
What
And
about the interval? Interval is very important.
Second arc zone. What about the interval between the opening snap and the second arc zone? A2 OS gap.
A to OS interval. This is very important.
So-
0.40 milliseconds interval will be there, sir. From
simply whether the A2 OS interval is narrow, what about the severity of MS? So the A2 OS interval is wide, what about the severity of MS? You don't need to tell about the values and all. It is very difficult to find out clinically. Just tell A2 OS interval is, if it is narrow, what is the severity of MS? If it is wide, what is the severity of MS?
So if it's a narrow, it will be severity of MS will be more, sir.
Okay.
If it is wide, there will be less severity. There is mild to moderate severity, sir.
Why in severe MS the A2 OS gap is narrow? In severe MS.
Severe.
Yes.
Sir,
Okay. What other findings
A2
will
will
get
be
in severe
close.
MS? Yeah.
Sir?
What other findings will get in severe MS? What other findings will get in severe MS?
There will be opening click. Opening click in. There will be a opening click will be there, sir. S3 will be absent, and diastolic murmur will be there.
Length of the diastolic murmur. What will be the length of the diastolic murmur in severe MS? What will be the length of the diastolic murmur? It will. Whether the severity of MS is proportionate to the intensity of murmur or length of the murmur?
Severity is in MS, the severe intensity of the murmur, sir.
No. It's the duration of the murmur. In mitral stenosis, it is the duration. It's the length of the murmur is more, you get the severe MS. Whereas in pan-systolic murmur of mitral regurgitation, it is, or aortic stenosis murmur of ejection systolic murmur of aortic stenosis, that is the intensity of the murmur. Whereas in mitral stenotic murmur, low pitch murmur, it is the length of the murmur. It's a long murmur, then it is severe MS. Okay.
Abhinaya,
Sir.
I mean, ഒരു murmurs increase and aspiration. You said like that. Okay. What is D Carlos sign? What is Carlos sign?
Murmurs increase on expiration, sir.
Aspiration or
No,
inspiration?
Inspiration.
Right side events, left side events. We should separate it. What about right side
For
events?
this, right-sided events increase on inspiration, sir. If it's left-sided
That's
events,
Carlos.
it increased on
Okay.
expiration, sir.
Okay. Which one is not obeying Carlos sign?
HOCM, sir.
No. Right side
I put
event.
it
Which clinical event? Which clinical event
Clinic
doesn't
event
do?
is
All
not
the
obeying.
right-sided murmurs, all the right-sided
Systolic.
murmurs are right-sided heart sounds will increase on inspiration.
Which one?
Except what?
Systolic click, sir.
Ejection
What
click.
click?
Pulmonary
pulse.
ejection click.
Pulmonary
Pulmonary ejection click. Okay.
Why? Why it's not obeying the Carlos sign? So when the pulmonary click happens, what is the reason behind the pulmonary click? When it happens? It is a sudden opening of the.
Will be there. When pulmonary stenosis will be there, pulmonary click will be there, sir.
Okay.
Or in.
Yes, you are right. So pulmonary ejection click is due to opening of the pulmonary walls of the sudden opening of the pulmonary wall. Similar to your sudden opening of the stenosed pliable mitral leaflets cause opening snap in that is we call opening snap in mitral wall. Similarly, the pulmonary wall, the sudden opening of the pulmonary wall produces the pulmonary ejection click. So here, in case of pulmonary stenosis, the RV end-diastolic pressure is already more. In case of severe valvular pulmonary stenosis, the RV end-diastolic pressure, RV EDP, is already high. So the valves are already in a state of partially opened state. Are able to understand? So the RV EDP or RV end-diastolic pressure is more. So the valves are already in partially opened state. So your maneuver of inspiration causing increased venous return to right side of the heart, it's not going to open the pulmonary valve. Already the valve is open because of the increased RV end-diastolic pressure due to pulmonary valvular stenosis. So the increased inspiration, by doing increased inspiration, it's not already it's happened. The opening of the valve is already happened due to raised RV EDP. Okay, so the maneuver of inspiration producing increased venous return to right heart is not going to open the valve because already the valve is open. So it does not obey the Carvalho's sign. So pulmonary ejection click on inspiration does not increase or does not augment. The valve does not augment on inspiration. Are you able to understand? Are you able to understand or not?
We understand.
புரிஞ்சுதா புரியலையா?
Sir, understand, sir.
Carvalho's signல all the Carvalho's signல என்ன பண்றோம்? Inspiration அப்போ venous return will increase to right heart and the right sided events will increase. Right sided event, whether it's a heart sound or whether it's a murmur, the right because of the increased venous into the right heart, then there will be increased flow and increase. So here in case of pulmonary valvular stenosis, the RV end-diastolic pressure is already high because of the valvular stenosis. So the valves are already in partially open state. So your maneuver of inspiration, increasing the venous return, is not going to newly open the valve and producing or increase the click sound because it is already in open state. Okay. So pulmonary valvular ejection click does not obey the Carvalho's sign. Are you able to understand?
Okay, sir.
Okay.
Abhinaya.
Sir?
What are the other features, but to differentiate which one is severity? Severity is whether it's MS or MR.
Sir, loud S1 and the apical
Okay.
impulse. Apical impulse in MS, it's
Okay.
only shifted outwards, not downwards. One
Okay.
is, and it's not, there will be no systolic thrill if it's if it's MS, and S1 will be loud, and there's no opening snap will be there, and there will be diastolic murmur will be there, sir.
Okay.
So regarding the
what's
A to OS gap, you said that why is it is short in the severe MS. In severe MS, the left atrial pressure is more. Okay, the high left atrial pressure results in early opening of the mitral valve. So OS come earlier. So it comes close to A2 because of the high left atrial pressure causing early opening of the mitral valve. Whereas in case of mild mitral stenosis, the LA pressure is low. So the opening of the mitral valve will be opening stop will be late. So it comes sometimes late after A2. Are you able to understand?
Yes.
Okay. Vinaya, what's the difference between
Yes.
opening snap and S3? While auscultation, it looks similar.
So if
What is
it's
it?
opening snap, it will be high pitch. If it is S3, there will be low pitch. The character will be snapping on OS and thudding on S3, sir. And if it is there will be increase in interval while patient do some maneuvers, sir. But it is S3, there will be no change, and there will be interval will be more in S3, sir. The interval
Which
between
interval?
more in S3, and if it's opening step, it will maintain between 30 to 150 milliseconds, sir.
Which interval?
A2 is
Sir is asking the difference between OS and S3. Both are additional sounds. Both are additional sounds had. So you'll be confused whether it is a opening snap or it is a tada sound. Sir is asking how to differentiate clinically. So opening snap is widely heard between the apex and the left sternal border.
Opening snap
Opening snap so widely heard. So S3 is localized to apex. Then all other points you said it is S3 is low pitched, OS is high pitched, and all those things.
And it's best heard with the diaphragm. So if it is opening snap, it's best heard with the diaphragm. If it's S3, it's best heard with the bell of the cervix.
Okay. It's a low pitched sound, it is a high pitched sound. Voice is a high pitched sound. Okay.
So you said is post anterior mitral leaflet involvement. What are the conditions produce anterior mitral left problem? What are the conditions post mitral leaflet?
MI, sir, if it is posterior mitral leaflets have a single blood supply, sir. So in anterior has a dual anterior has a double blood supply. So anterior valves have a dual blood supply, sir. So any MI any inferior wall MI which affect posterior leaflets.
So
it's
normal
not leaflets. It is a post papillary muscle. I mean, you're talking about papillary muscle, not leaflet. You're talking about papillary muscle, posteromedial papillary muscle and anterolateral papillary muscle. Posteromedial papillary muscle has got a single blood supply from posterior descending artery from right coronary artery, whereas anterolateral papillary muscle is supplied. It's got dual supply from one is from LAD and another is from circumflex. So there is a reason for MR in case of inferior MI. It involvement of posterior descending artery for RCA, and even in case of anterior MI, if the anterolateral papillary muscle is involved, you may get due to LAD territory involvement, you may get MR there also.
Okay.
What are the changes occurs in mitral valve apparatus in rheumatic fever?
It will be shortened, sir.
Which one shortened?
Uh,
So மூணு தான் wall cusp, commissure, then chordate tendon.
What are subvalvular apparatus? What are the subvalvular apparatus?
Apparatus.
Yes, chordate tendon which attaches to the papillary muscle.
Papillary muscles to the to endobody.
How many papillary muscles in the left ventricle?
Two.
Two. Just before we discussed posteromedial and anterolateral. Okay. Cusp, mitral valve cusp, then chordate tendon, then papillary muscles.
Ventricular veins.
Papillary muscles. Okay.
Papillary muscles. Left ventricular veins.
So what is your probable diagnosis? Is it rheumatic or anything?
Sir, there will be if it's a acute MR, we can think of rheumatic or infected endocarditis or MI, sir, or even a left atrial myxoma, sir. If it is chronic,
Well, our question is whether it is acute MR or chronic MR. With your clinical presentation, whether it is an acute MR or chronic MR.
It's in a chronic MR, sir, because a patient have patient have symptoms of papillary capillary wedge pressure. There is a PND will be there, and there is a progressive dyspnea, and along with examination, the apical impulse will be shifted outwards and downwards, and systolic thrill, along with the grade 4/6 murmur. So which all this indicate it's chronic MR, sir.
Okay, fine. Did you hear the word rocking motion over the pericardium in MR? கேட்டிருக்கீங்களா அப்படி?
No, sir. Rocking motion scalable.
What is why?
Because of shrinkage, because of art while during contraction, it rotates both in clockwise and anti-clockwise direction, sir. That's that.
Which one is expansion? Which one is a retraction? ஒரே டைம்ல retraction வரும் expansion வரும். எது?
Sir, if it's a left ventricular apex, there will be a medial retraction, sir.
சரிப்பா.
If it is lateral retraction, which indicates right ventricular apex.
இப்ப ரிசீவ் பண்ணிக்க வயசுல ரிசீவ் பண்ணி ஓட்டு ரைட் ஆர் 20 கொடு.
Okay, what are the supra? Do you hear the word supra AS ல என்ன இருக்கும்?
Sir, supra
AS. Williams syndrome கேள்விப்பட்டிருக்கீங்களா? Williams syndrome.
Yes, sir. It's an supravalvular AS. Elephant facies will be there, sir.
Okay, then.
Sometimes hypercalcemia will be there, sir. As a patient presented with sometimes MR will be mental retardations will be there, sir.
Go and read about Coyanda effect in its problem. Yes. Okay. Sorry.
Abhinaya, you said a pansystolic murmur in the apex. What are the differential diagnosis? Straight away, you want to say CPR or you want to rule out anything?
Sir, pansystolic murmur will be seen in along with mitral regurgitation, tricuspid regurgitation, and ventricular septal defects. We can see pansystolic murmur, sir. if it's a ventricular septal defects, means the patients will have the age will be patient will have age manifestations. So the presentation of age will in VSD will be engaged, sir. If it is tricuspid regurgitation, means we can get the epigastric pulsations will be there, and
what is the localization of the murmur? If it is VSD, if it is tricuspid regurgitation, where will you get the murmur?
if it's VSD, we can get in third neo-aortic area, sir.
Okay. Okay. If it is tricuspid regurgitation,
In
lower left sternal border.
lower left sternal border at fifth lobus.
Then again, as Ramesh, it will obey Carvalho's sign. On inspiration, the murmur increases. Tricuspid PSM will increases on inspiration because of increased venous return to right heart. Okay. And you said chronic MR. Then why the patient has got symptom after 60 years if it is a chronic MR?
Sorry, chronic MR.
What is the etiology you want to say? If it is a chronic MR, what is the etiology you want to fix for this chronic MR?
Mitral valve prolapse or ischemic heart disease.
Ischemic heart disease.
Dilated cardiomyopathy.
Okay.
Or atherosclerosis. Atherosclerosis or a patient will have if it's a rheumatic also present. Rheumatic heart disease also present later.
Rheumatic heart disease. So before that he didn't have any symptoms, and after 60 years only he got symptoms.
No, sir.
It is
No,
rheumatic
sir.
heart
Initially,
disease. Initially. So this 60-year-old man, he was asymptomatic before. All of a sudden he got some exertion dyspnea.
Some
and PND all of a sudden after 60 years means first you have to fix should be an acquired mitral valve. Well, mostly as we discussed, maybe a coronary artery disease or ischemic heart disease that may affecting the papillary muscle. That might lead to papillary muscle dysfunction or caudal rupture. Okay, that led to the MR.
If it's a chronic, we have to look for any myxomatous degeneration of the valve. We have to look for, sir. Or sometimes dilated cardiomyopathy also present, or any valvular calcifications which also present as a chronic MR, sir.
Dilated cardiomyopathy producing MR will be a mild. That won't be having this much harsh pansystolic murmur. Have you ever had a harsh pansystolic murmur in a case of dilated cardiomyopathy in your clinical rounds? Have you auscultated? We are seeing so much of dilated cardiomyopathy patients because of increased LV end diastolic pressure. Because of the increased LV end diastolic pressure, the blood will be getting regurgitated into the LA. That will be a mild MR, sometimes maybe moderate. So that need not produce a harsh, blowing pansystolic murmur, isn't it?
Yes, sir.
So any old age, whatever, if you are telling a diagnosis of mitral regurgitation, irrespective of whether it is acute or chronic, that mostly it may be due to ischemic etiology. In old age, mitral regurgitation, pansystolic murmur in old age, if you are more than 60 years, pansystolic murmur means you got to, it may be mostly due to CAD, coronary artery disease, producing mitral papillary muscle dysfunction. That is the first differential diagnosis you have to fix. Then comes the rheumatic. Okay. Similarly, if it is aortic stenosis, ejection systolic murmur of aortic stenosis, the first in the old age 60 plus, you have to first fix the diagnosis as a degenerative aortic valve disease. Degenerative aortic valve disease. Then only you have to come for second diagnosis as rheumatic heart disease. Mostly rheumatic heart disease will have, apart from mitral heart disease, all other pathologies will have associated other valves also, like my MSMR, ASAR, or MR plus AR or MR plus AS, like that. You will have combinations, mostly multivalvular presence. Whereas in mitral stenosis, most of the time it presents isolated, that we can fix, boldly say, rheumatic. But in old age, if involving mitral heart alone producing mitral degradation or aortic stenosis producing systolic murmur, the commonest etiology will be ischemic etiology in mitral valve, whereas degenerative etiology in aortic valve disease. Okay.
Okay.
Yes. Whenever you got a severe mitral regurgitation or severe mitral stenosis or severe aortic regurgitation, you have to carefully look for signs of pulmonary hypertension. Any single you got to any one finding you have to search for the finding, because without the existence of pulmonary hypertension, the patient may not have such symptoms like dyspnea, PND, and also with a severe mitral valve disease or severe mitral regurgitation, severe mitral disease. All those things will produce increased left atrial pressure that will be reflected back into the pulmonary veins, that narrows pulmonary venous hypertension, and over a period of time, pulmonary capillary wedge pressure increases, and finally will land up in pulmonary hypertension. So the severe MR or severe MS or severe AR, whatever may be, you should carefully look for, you should search for findings of pulmonary hypertension, at least a parasternal key or a loud P2. And you have to, at least there may be a mild pulmonary hypertension to produce all those things. Or you have to justify your answer, like patient might have been on diuretics. When I did the clinical examination, the patient has been treated well, and all his pulmonary congestion has been drained out by diuretics, and so I am not able to get any features of pulmonary hypertension. You have to substantiate like that. Otherwise, most of the time, whenever you are fixing a severe lesion, severe valvular heart disease, usually you will have pulmonary hypertension. So that you don't forget. You search for whether there is elevated JVP, parasternal heave, loud P2, all those things. Okay, go ahead.
Okay, sir. It's an ECG of the patient, sir. It's an 12-lead ECG with the normal standardizations, with rate is around 75 beats per minute, which is in a regular rhythm. The P wave will be present, and there will be no axis deviations will be there, and PR interval will be normal, and
So what are the clinical ECG findings you expect in this case before opening and reading the ECG?
sorry. If it's Emma, we have to look for any left atrial hypertrophy or left ventricular hypertrophy, or we have to look for any atrial fibrillation, sir.
Very good. Left atrial enlargement, left ventricular hypertrophy.
Left ventricular hypertrophy, sir.
How will you know it is a left ventricular pressure overload or volume overload in ECG? Is there any finding? Is there left ventricular pressure overload hypertrophy or left ventricular volume overload in ECG? So if it is a left ventricular pressure load, you will get LVH strain. What do you mean by strain? You will get a
T-wave inversion, sir. It's with the T-wave inversion.
ST depression, T-wave inversion, and V5V6 left side, L1 AVL. Whereas if it is a volume overload set, you will have a tall T wave, tall R wave along with a tall T wave. The T wave will be upright. In the case of severe, if you notice a severe MR or severe AR patients volume overload set, you look the T wave of the V5V6 leads, you will have an upright T wave rather than the inverted T wave. That if there is upright T wave, that indicates the volume overload of the LV. Also, you will get a Q wave in V1. That is also a sign of left ventricular volume overload. Q wave in V5, V6. That will be deep Q wave. Okay. And also Q wave in V1. Usually you'll get a small R and deep Q in V1. If you get a initial Q, then that is also QR pattern in V1. That is also a volume overload state. Yes.
What about P wave in V1, pa? Abhinaya.
Sir,
P wave in
P
V1.
wave in a normal patient, sir.
In this patient.
Here the P waves will be here the P wave will be inverted, sir.
Okay. If it's positive in an inverter,
If it's inverted, so if it's inverted, which indicates left atrial hypertrophy, left atrial enlargements. Like P wave is inverted, which indicates left atrial enlargements. If P wave is biphasic, which indicates there is any bundle branch, any atrial. There is interference in atrial conductions. Any block will be in
Left atrial enlargement with right ventricular hypertrophy. What is the common clue? If you get features of left atrial enlargement along with right ventricular hypertrophy.
left atrial enlargement. Mitral regurgitation, we get left atrial enlargement along. Sorry, left atrial enlargement. MS will we get a left atrial enlargement with the right ventricular hypertrophy, sir.
Okay, right atrial enlargement with left ventricular hypertrophy.
So left atrial enlargement with the left ventricular hypertrophy, mitral regurgitation, we can get left atrial enlargement with left ventricular hypertrophy, sir. Or in severe AS, there will be left ventricular
right
hypertrophy
atrial
followed
enlargement with left atrial hypertrophy. Left ventricular
sir,
hypertrophy.
right atrial enlargement with the left right any valvular septal defects we can get, sir. Right atrial enlargement with left ventricular hypertrophy with septal defects.
What about Epstein's anomaly? Epstein's anomaly.
Right to
you'll get a giant right atrium. You'll get a Himalayan P waves. Okay. And there won't be any features of right ventricular hypertrophy because the rudimentary RV. Okay.
It's na. So shall I move on? Shall I
Move on.
keep?
Shall I move?
Shall I?
Can move.
So this is X-ray of the patient. The patient name is just X-ray with the PA view, trachea with the normal, like with adequate exposure, with centralizations, with the trachea appears to be in midline. Here, there will be prominent bronchovascular markings will be there, and left out border will be no prominent broncho. There is no cardiomegaly and cardiophrenic and costophrenic angles will be normal, sir.
Yes. What are the features of pulmonary hypertension? Generally, you look in chest X-ray.
So in supplementation of veins will be there, and the curly B lines will be there, sir.
Okay.
And curly B lines. We have to look for any right ventricular enlargements will be there in pulmonary hypertension, sir.
Okay, good. What will happen to the pulmonary vasculature in severe pulmonary hypertension? Vascular markings. You will get pulmonary oligemia. pulmonary oligemia in severe pulmonary hypertension. Okay.
So, and pruning of peripheral pulmonary, pruning of pulmonary arteries will be we can see pruning of pulmonary arteries will be seen, sir.
Okay, good.
Or
What are the causes for
right atrium will be enlargements. Straightening of ear, the straightening of left heart border will be there, sir.
So why it happens? Straightening of left heart border.
Straightening of left heart border mostly commonly seen in mitral stenosis, sir.
Due to?
Because of left atrial enlargement.
Left atrial appendage gets enlarged. That occupies the, so the pulmonary bay gets obliterated. Usually you'll have a ditch beyond that in the left side. That we call pulmonary bay. That area will be occupied by the enlarged left atrial appendage and LA. So that makes it straight. Okay.
What are the other findings, X-ray findings in mitral stenosis?
So left atrial enlargement will be left atrial enlargement will be there, sir. And straightening of left heart border will be there. There is no prominent bronchovascular markings will be there. And
Okay. What is double atrial share of?
Splayed carina will be there. Splaying of carinas will be there, and sometimes
Okay.
curly B lines and the curly A lines will be there, sir. And due to left atrial enlargement, there will be a shadow within shadow sign will be seen, sir.
Go ahead.
Yes, you can move on. Abhinaya.
Go on, Pa.
Sir, it's the end of this slide, sir.
Echo, what about the echo, Pa?
So echo which shows severe mitral regurgitations with the ejection fraction of ejection fraction will be 60, and at the normal left ventricular systolic functions, they shows chordal rupture. So they shows minimal chordal rupture. So they proceeded to transesophageal echo. In transesophageal echo, there will be
which leaflet is involved, Pa? Abhinaya, which leaflet is involved? Which leaflet, Pa?
It's a posteromedial leaflet, sir.
Oh, if your murmurs radiate to precardium, a base of the heart, isn't it? But you said as in axial and inferior scapula.
Sir, here, allowing while the patient went for transesophageal echo, so here along with the posteromedial, there will be an anteromedial along with posteromedial leaflet will be involved, sir. Cardiac ruptures will be there.
Usually in cardiac rupture, there is involved a posteromedial leaflet. In rheumatic fever, it is anteromedial leaflet.
Yes, sir.
Palamur, sir.
Yes, it's she presented unbiased. She know the case very well, but very unbiasedly she presented very nicely, narrating the history and all the clinical features, and you must answered almost every questions. Well done, Dr. Abhinaya. You've done a good job. It's a good case presentation, good case. But did you follow up the patient's coronaries in this patient? Because you should be eager.
Sir, coronary
what is the cause
angiogram,
for this caudal rupture? What is the cause for this caudal rupture in this patient? Did you follow up the coronary angiogram in this patient? You didn't follow.
Says I went to cardiology department and they coronary angiogram done, which shows proximal RCA will be involved, sir.
Did you follow
The
the
nominal
patient's original angio report or not? I'm asking not what will be the finding, anticipated finding. Did you follow the coronary angiogram in this patient?
Normal epicardial coronaries. They done a norm. They showed a normal epicardial coronaries.
You came and see the angio or not? Okay, tomorrow you come and see the angio, and because you have narrated all those things, everything, you should be eager. What is the cause for the caudal rupture? whether it is due to the ischemic etiology and another common one thing is infected endocarditis. Those things may produce caudal rupture or degenerative, as you said, degenerative ixomatous rupture. You should fix the etiology. So coronary angiogram has been done. You follow the coronary angiogram reports also. And how will you manage this patient? How will you manage?
So if it is acute MR, if it is if
So now
it's
you
both
know
medical and
it is
surgical
a severe
management.
MR.
I
Severe
said
MR with
it's
patient
a
is presenting with
medical
dyspnea.
management and surgical
Breathlessness.
management.
Okay.
Medical management, surgical management will be there, sir.
Okay.
If it is
Okay.
medical, if it is in a chronic means we have to go for a
No, the
ACE
case is
inhibitor,
given
sir.
to you. What are you going to do? You know the diagnosis. Case is given to you. What are you going to do? You know the case, your echo, everything. What are you going to do now?
Medical management, sir.
Initially, you will stabilize the patient by medically. By what?
But the ACE inhibitors, along with the
First, the patient presented with
anti-failure
dyspnea. Yeah. First, you get to start with diuretics.
anti-failure measures.
Diuretics. Then NTG. Must reduce the.
So on night NTG diode, so in acute medical and surgical, sir. If medical, we have to go for intravenous nitroprusside or a nitroglycerin, sir. Because we have to reduce the afterload. We have to reduce the afterload, sir. Or we have to go for anti-failure measures if the patient presented with the palpitations, sir. So we have to, if palpitations due to AF, we go for anticoagulation measures, sir. Or if it's due to
there is no in this case. No AF in this case. You are just going for the antifailure measures. Where you are going to treat by diuretics, NTG, beta blockers, and stabilizing patients. Once the patient is stabilized, what do you want to do?
We go for a repair, sir. Repair, and we go for a surgical.
So that you got to rule out whether it is due to any coronary artery disease producing this problem. You have to do a coronary angiogram and rule out coronary artery disease. Then you have to go for a transesophageal echo there to rule out any infective endocarditis or vegetations causing this rupture. So you have to do a coronary angiogram, transesophageal echo. So after doing all those things, then stabilizing the patient with medical management, you have to fix the valve. What surgical procedure you want to do? What surgical procedure you want to do? Valve?
Repair, sir.
Okay, good. You have to go for valve repair.
Annuloplasty.
Very good, very good.
Annuloplasty.
Good. Okay, Ramesh?
Okay.
You want to conclude? Shall we conclude or?
Yes, sir, we can conclude, sir. Yes, sir. It's nice presentation. You almost answered our questions. We can conclude the session, sir. I thank HOD, sir, and API for giving me this opportunity. I thank Balamurugan, sir, for sharing the session, sir. Thank you.
Thank you, Ramesh, and thank you, presenter, and thank you, the PGs, other PGs who are with us.
Thank you.
Thank you, sir.
Thank you.
ಈ ಎಕ್ಸಾಮ್ಗೆ ಎಲ್ಲಾನು ಸಿಗುತ್ತೆ automatic ಇದೆ ಮಿನಿಸ್ಟ್ರಿ CVS ಇದ್ದ
Is meeting done, sir? Hello? Meeting get over? Hello?